Hello and welcome, and thank you for joining us on this chilly November evening. My name is Henry Assad. I'm a fourth-year dental student at McGill University, and we have a very riveting discussion for you tonight at Coalition for Dental Care on the topic of how publicly financed dental care is delivered in Canada versus in the United States. We have two practicing dentists, one Dr. Hoan Nguyen and Dr. Ivy Lin. Dr. Hoan Nguyen received his DMD from the University of Montreal in 2009. He worked in private practice until 2013 when he accepted a full-time position with the Dental Health Services at Ottawa Public Health. While working there, he completed an MBA from the University of Ottawa in 2015. Since 2018, he has been the Supervisor of Dental Clinical Operations at Ottawa Public Health. Thanks for joining us, Dr. Nguyen.
Thanks for having me.
And then we have Dr. Ivy Lin. Dr. Ivy Lin grew up in Montreal before earning her DMD from McGill University in 2017. She subsequently joined the general practice residency at the University of Washington in Seattle. She has a strong interest in public health and organized dentistry. As a dental student, she has been involved with the Student Council, the Federation of Canadian Dental Student Associations, Oral Health, Total Health, and fundraising for the McGill Outreach Program. She is continuing her involvement in increasing access to dental care as a volunteer dentist on international humanitarian trips and as the dental deputy director of the Seattle King County Clinic, where free dental care is offered to thousands of people every year. Dr. Lin currently practices in both a community clinic and a private practice in Seattle, and also volunteers as an affiliate faculty member at the University of Washington School of Dentistry. So tonight's discussion, as previously mentioned, is on publicly financed dental care and how it's delivered in Canada and the US. Our audience is the general public, anybody who's interested, including dentistry students, researchers, hygiene students, dentalology students, and any other interested parties. So without further ado, let's get into our question. First, a little bit of background, doctors. So what brought you to work in a public health dental clinic? Dr. Lin, would you like to start us off?
Sure. For me, first of all, I volunteered a lot in charity organizations, in particular UNICEF. So I had developed very early on an interest in social justice. So coming into dentistry, I knew that I wanted to help increase access to dental care. And also, as a dental student, I quickly realized how dental diagnosis is subjective. For example, 5 dentists can have 5 different treatment plans for the same case. And given that finding, I felt a little uneasy that most dentists would be incentivized by monetary gains in helping their patients maintain their health. And you often hear, especially in practice management lectures, how much emphasis is put on production in most private clinics. And for me, that was kind of a turnoff. So when I found out about the model of practice of community clinics in Seattle, where I did my residency, it was very attractive to me since there's no pressure to produce and dentist salaries are not influenced by production. Also, because of this financial model in dentistry, I feel like there's kind of a trend of the general population losing trust in dentists, unfortunately. And as a new dentist, when treatment planning at the same time as diagnosing is already pretty difficult, and at the same time you have to sound confident about it. So I felt like, as a relatively new dentist, I feel judged by the patients sometimes, and in community clinics, patients tend to be more trusting, so it's less fearful. Patients tend to be more grateful too, so it's very rewarding as a dentist. And also in community clinics, there tend to be many dentists. In my clinic, there are 5 dentists, and it's always fun, and we can share cases together, discuss them. And it feels less lonely than working in a private clinic.
It's a really good point on how financial transactions can change the nature of a relationship. Yeah, Dr. Nguyen, how did you come to work in a public health dental clinic?
So it kind of just happened. It's so my mom worked in public health for a long time, right? She was a dentist as well, and she worked in public health for the majority of her career. So when I started working in private practice, can't remember how it happened exactly, but I started working 1 day a week with public health just to try something different here and there. And I guess around the time, around 2013 is when I started working full time. It's because I wanted to work on my MBA, and working in public health really had more regular hours, and it just allowed me to concentrate more on evenings and weekends on my MBA, right? I mean, what Dr. Lin said as well about not having to talk about finances with patients is always nice as a dentist. You know, you don't really have to focus about that. You don't feel patients. Well, yeah, you don't feel that patients think that you're pressuring them into certain treatments because you can gain from it, right? So it was something different for me to try, and well, still here 7 years after, right?
Yeah,
that's about it.
And so you started talking about the how your patients don't feel pressured because is it because they don't pay for the treatments, or are there any treatments that they do pay out of pocket, or are you only performing your clinic's reimbursed procedures? Dr. Nguyen, would you like to get us started?
I'm sorry, did you say me?
Yes.
Yeah, sure. So yeah, no, our patients don't pay anything out of pocket. I mean, I don't know how it works in the US, but here in Ontario, in Ottawa at the very least, there are a lot of dental programs, a lot of public dental programs that cover different populations here and there, right? So we deal with a lot of them, and with majority of them, or actually maybe all of them, there is no copay, and there is no extra billing that's allowed under the program. So patients really don't have anything to pay out of pocket. So in our clinics, we don't deal with any money at all. There's no transactions, financial transactions. I mean, it all happens in the back end, right? We still get reimbursed for some of the treatments we provide, or under some of the other programs, we're base funded. So let's say the province might provide a certain amount of funding for us to run our dental clinics and provide services to a certain clientele. And I guess basically whatever we don't use up of that funding goes back to the province, but we're funded to run operations. It's not based on a fee for service. It's not based on the procedures that we perform. Some other programs that we deal with are based on fee for service. So whatever we bill, we get reimbursed, but it's not through the patient, it's through whoever covers that program, right?
Dr. Lin, how about in Seattle? Is there primarily procedures performed that are reimbursed by whichever program, like whichever government publicly funded program, or do patients have a mix of paying out of pocket and reimbursed procedures?
So in the US, I think it's a more unified system as compared to Canada. My clinic is considered an FQHC, which is a federally qualified health center. And these are a little bit everywhere in the US. It's basically a reimbursement designation from the government saying that it's a clinic that primarily serves underserved populations and can get cash grants from the government, and also free federal malpractice insurance. In return, we have to charge for services on a sliding scale based on the patient's family income and size, if the patients don't have Medicaid. So Medicaid is in the US a program that helps with medical costs for some people with limited income. The coverage varies a lot by state, so it's determined by the state's budget. In Washington, we cover cleanings, exams, restorations, extractions, anterior endos, and dentures. But I know like in some other states, like Connecticut, for example, crowns and posterior endos are also covered. If a patient wants an uncovered procedure, they can apply for the sliding scale. We also have some private insurance patients in our clinic. We accept most insurances. And my clinic in particular, for example, because of its status as a QHC, we receive a certain payment per visit. And right now it's about $230. So it doesn't matter if we do a root canal in that visit or just a child cleaning, it's the same amount every visit. And I feel like it is an advantage in some sort compared to private insurance because it tends to focus more on prevention rather than treatment, because we get paid the same for giving some oral hygiene instructions or doing a really complex treatment. In terms of compensation for dentists, we're all paid by annual salary, and it's based on the years of experience that we have. So there's no pressure, as I said, to produce at all.
So you mentioned the sliding fee scale, Dr. Lin. Do patients have to submit some sort of proof of income, or is it open to everyone? How does that work?
Yeah, it's open to everyone, and you just have to submit your tax returns, I think, and your paycheck. I'm not 100% sure of exactly how it works. Usually the front desk takes care of that.
Okay. How about in Ottawa, Ontario? How does that work, Dr. Nguyen?
So yeah, generally patients do have to show some kind of proof of eligibility on a program. I know I mentioned there are a lot of programs, right? Some of them are federal, some of them are provincial, some of them even municipal. So we can think of off the top of my head at least 5, 6, 7 programs that we deal with. So depending on the program, there are different proofs of eligibility, right? So the provincial programs, for example, the patients will have a card that's mailed to them by the program administrator, and it just has their name and an expiry date, right? So they just show that to us, and we know that they are covered during that up until the expiry date. Some of the other programs we deal with, the municipal programs, we actually have access to the database from our community and social services department, so we can verify eligibility directly there. So yeah, patients generally do have to show some kind of proof, or we can access that ourselves. Was there something I was going to say about that? Oh yes. Now there are patients who don't have any coverage and still show up to our program, to our clinics, right? So in those cases, they don't have anything to show. They're not covered on any dental program, but we still deal with those cases. I mean, ethically, as a dentist, someone shows up in pain, you still have to treat them, getting them out of pain at the very least, right? So we do those one-off emergencies, and we don't request any reimbursements for those.
Okay. And do you accept private insurances in Ottawa?
Oh, so like I said earlier, we don't deal with any cash. So private insurances generally do have some kind of copay. So we don't deal with anyone who has any private coverage. So everything is publicly funded, or like I said, those one-offs that we just absorb the costs.
Okay. So from what I'm gathering, that in Ottawa, all the procedures are publicly funded. Other procedures that are performed are publicly funded. You don't deal with private insurances. It's not a fee scale. But in Seattle, there's a bit more of a mix between you accept insurances, you accept out of pocket for non-reimbursed procedures, and then you also have a sliding fee scale for people on low income, and you accept Medicaid and Medicare.
It's mainly Medicaid. Medicaid in the US is for those with lower income. Medicare is more medical insurance for 65 years old and above, and usually doesn't cover dental.
Okay, thank you for that clarification.
Mm-hmm.
So you touched upon how the dentists are paid. Doug, could we recap that? In Ottawa, they are paid on a salary, on a fixed salary.
Right. So our dentists are all paid on a salary. That's right. It also depends on the years of experience, as Dr. Lin mentioned, but it's a rather small scale. So most people get to the top rather quickly and stay at the same salary.
Okay. And in Seattle, it's mixed. It's per procedure or salary.
So we're all salaried. We get a very small bonus based on a few factors like production, patient satisfaction, the number of visits that we have every quarter, but it's only like less than 10% of our salary, and not everyone gets it.
Okay.
But there are also a lot of benefits, which attracts a lot of dentists in that way. In working in community clinics here, you have paid vacation, health and dental insurance, retirement accounts. We have money to spend on continuing education too. I think those things are more feasible for a community clinic like ours because of the size of the organization. There are 5 dental clinics as part of our organization. So private clinics will be a lot harder to offer those benefits. That's pretty much it.
Okay, and so moving away from financial transactions, how about for the choice of material selection or instrument selection? Are these items selected by dentist clinic manager or a non-dentist clinic manager? Who decides what the clinic buys in terms of sundries and other equipment? Oh, Dr. Nguyen, would you like to start us off?
Sure. So materials and instruments that we use are all chosen by dentists. We've always had a dentist who's, I guess, in a supervisory role or a management role, right? So, but it's not necessarily that dentist who makes the decision. It's a decision as a team that we make with all of our dentists. We try to reduce wasted materials, and we don't want to have too many types of the same similar type of materials so that they'll end up expiring if they're not used, right? We have a lot of dentists who work part-time, for example, or some people come and go. So if everyone just ends up buying what they want, then we might end up with a lot of waste. So we try to agree on a smaller amount of selection, I suppose, of materials that we'll all use for a while. And I mean, part of what we do being public funded is we do actually have a purchasing bylaw of the city of Ottawa where if you're spending about a certain amount on a certain type of item with one company in a year, you actually do have to go out to tender and you go for a request for quotes. You get bids on the items that you're requesting quotes on, right? So, I mean, our clinics have been around for a while, so we know we have a pretty good idea of how many cartwheels of anesthetics we're using per year, or containers of disinfectants or whatever, right? So we'll just get a quote for the amount of items we'll use within the year, and whoever bids on it gets their business for, let's say, 3 years, and then they keep the price low for those materials that we use, right? So generally, when we want to change materials we use, we wait until that contract is up, and then we'll decide on a new material. Now, we don't necessarily have to stick to that contract. We can buy things outside of the contract, but they'll cost more, and there's a risk of wasting the materials if not everyone's using it, right? So we do generally try to stick to that list of materials.
And how does that work in Seattle, Dr. Lin?
Yeah, so as I mentioned, we have 5 dental clinics in the same organization. So for all the clinics, there's a set list of materials that the lead dental assistant can order from. And each clinic's dentists, they'll see which materials get used more, and then as they're getting used, they'll order more. But dentists can request for materials that are not on the list to be added to the list, but we have to provide evidence, like articles that prove that this material is gonna lead to better outcomes for the patients than what's already on the list. So you can't get something that's super expensive and doesn't add as much value to the care. And then the request is sent to the dental director of the organization, who is a dentist. So yeah, we have a non-dentist clinic manager, but they don't have much say on what tools or materials that we use.
And I'm assuming this also applies to larger purchases, like larger equipment purchases that might have a larger price tag?
Larger ones are probably, we can suggest it, and the dentist can suggest purchasing them, but the ultimate decision is left to the dental director.
Okay. So Dr. Nguyen, you mentioned that you have a bidding system for for large contracts. Have you found that this is a good way to decrease costs?
Yeah, no, it does work rather well. The way, I mean, depending on the contract that we have, generally might last for 3 years, and during those 3 years, the cost will barely go up, right? So the longer we keep the contract, the lower the costs end up being. And we generally do have extensions of those contracts. So as long as the supplier wants to extend the contract and we want to extend it, we can go on for quite a few years, right? So we can keep prices very low and they won't increase very much over a long period of time. It does, like I mentioned earlier, limit what we can order at that price. So sometimes we will order outside of that list of items, but it certainly does offer considerable savings.
So you can extrapolate that if there were more clinics, more publicly funded dental clinics, then you can have even greater savings.
Well, I mean, so here in Ontario, we have the Ontario Dental Association, and they have their own, they have a contract, similar contract that they provide to their members, right? So of course, the more people you have, the more purchasing power you have, right? So yeah, no, it is done at larger scale as well with private dentists.
Okay. So having worked, actually follow up on that previous question, how are other variable costs managed? Like costs that kind of go up and down throughout months that you might not have planned for in the budget?
Well, like I mentioned earlier, some of our funding is base funding, right? So the province gives us a chunk of money, and it can be for salaries, rent, materials, whatnot, right? So whatever we don't spend within that budget within the year, then we send back to them. So generally, we do have room to absorb those costs. I don't think we've had too much of a problem with that.
Okay, Dr. Lin, do you have anything to add?
I know dental instrument companies like Henry Schein gives discount to our community clinics, which help a lot. We don't have a lot of lab expenses because we do pretty basic procedures. We do have employees in the organization that apply for grants on a regular basis, both public and private. There are occasionally some rich donors who are looking for local nonprofits to donate to, and we always try to take advantage of those opportunities.
Okay, that's interesting. Interesting note about the philanthropy. Does that ever happen in Canada?
Well, it does happen, but not with our organization specifically, right? There are dentists who will provide pro bono work here and there. We do have a clinic in the Ottawa Mission, which is a homeless shelter, where dentists will volunteer their time, but not with our organization specifically.
Okay, thank you. So, having worked in and administered public health dental clinics, do you feel that this model of delivery would be well suited to provide care to underserved populations or communities such as those in schools, long-term care facilities, prisons, and rural and Indigenous populations? Dr. Lin, would you like to start us off?
So in Washington, and I think in many other states, there are already public health dentists working in rural and Indigenous communities that are very similar to the ones that I'm working in, with similar benefits and scope of treatment. So I definitely think that it's a model that works well for those communities. In our community clinic, there are actually volunteer opportunities as part of my work, where we go to schools to do visual exams and place sealants on the kids, and then we refer them to our clinics if we see that there's a lot of decay and needs. So that's pretty neat, and to encourage the dentists at our organization to volunteer for those events, the organization actually gives an increase in our continuing education allocation every year if we volunteer at least once every year. But of course, the organization is able to give that money and to do all this because of the $230 per visit that the government gives us for each patient. So if such an agreement was not in place, then if we're reimbursed per procedure billed, I think that would be hard to implement in schools.
Right. How about you, Dr. Nguyen? Do you have anything to add from the Ottawa, Canada perspective?
I don't have much experience with what goes on with the prisons and the rural and indigenous communities, so I can't speak too much about that. I do know here, I believe in Ontario, there are dentists who go into the detention centers and provide work there, and I think they are paid by the province, I think. So yeah, it's not private dentists going in, I think. Here in Ottawa, we did have dentists in the past going to long-term care facilities, but we didn't carry, a compressor and dental equipment with us, right? So it's more of a visual exam and referral if needed, and oral hygiene instructions, fluoride varnish, just consultations, right? We haven't done that in a long time, and it's difficult work, right? Not many dentists enjoy doing that kind of thing. It's not very efficient use of time. So what we find these days is there are some private organizations that go into long-term care centers, and they basically, that's all they do, right? They have a team of dentists that go to different long-term care centers. Like there's Golden Care Services, I think they're called, or Multigen here in Ontario. So they cover probably most of the long-term care facilities between a few of these organizations. So that seems to be working rather well right now. There are a few public health units that have buses or vans, dental buses or vans to go serve rural communities, but we haven't really done that here in Ottawa.
Right.
Yeah.
So you mentioned that this type of work is not always the most efficient use of dentists' time. What would you say about the role of expanded function dental auxiliaries in this context? And I know that varies from state to state and province to province, but from your perspective, what is their role in care to these populations?
So, I mean, we haven't had a lot of expanded duty assistants or hygienists in our practice, but assistants and hygienists do go out in the community in Ottawa and provide dental screenings. They do the screenings in schools for children, for example. And they can apply for the hygienist can apply fluoride varnish without a dentist on site. So there's a lot of preventive work that can be done by the hygienists in the community without having dentists around. Otherwise, I mean, there's something that's probably coming more and more. It's teledentistry, something that we might have seen a bit more, we might have heard about more during the pandemic. But what I mean by teledentistry is not just face-to-face video interaction with patients, but I mean having someone go in with an intraoral camera and take pictures and have a dentist diagnose either real time or after the fact, take a look at whatever might be of concern for patients and make referrals if needed, right, without having to go on site. So that's probably something that's going to be a lot more useful in the future as the technology develops.
Dr. Lin, from the United States perspective, and I know it's very varied from state to state, but how do you see the roles of expanded function dental auxiliaries?
So we don't have expanded function assistants or therapists in our clinics. We do have hygienists, and I think they're pretty important in our clinic function. Dentists don't like doing cleanings, so we do have 1 or 2 hygienists at all times. And I think it's great because it's very effective at doing prevention to prevent, perio disease and to apply fluoride on kids and things like that. But it is pretty difficult for us right now to hire hygienists. There's a shortage of supply. I think right now the hourly wage for them can go up to $70 an hour, which is pretty much what the dentist makes at the community clinic. So there's a lot of competition for hygienists right now. For dental therapists, I know the Washington State Dental Association has been fighting against a bill to make a program for dental therapists in Washington. I think they're a good idea if we were to get universal dental care. If we think that there's a higher percentage of the population that's gonna get dental care and there's not enough dentists to meet the demand. But from previous experience with dental therapists in other provinces and states, I think the main problem was that we wanted to increase access in rural areas with dental therapists. However, they will, like everyone else, tend to rather stay in urban areas. So we need to make sure, I think, that we give them enough incentives to move out of urban areas.
Mm-hmm. Or if incentives aren't enough, some have talked about having it regulated in such a way that they must be employed by a public health agency or public health dentist. What do you think about this?
I think if we can put in regulations for them to limit them as well, it could work. But I think even because in the US, especially, there's so many community clinics in urban areas, if we just put a limit on them having to work in a community clinic or a publicly funded clinic, I don't think there's a lack of dentists in urban areas. So I think there's a lot more dentists than there should be in cities. So I don't think there's a lack of providers here.
Dr. Nguyen, do you have anything to add?
Yeah, so Dr. Lin talked about dental therapists. We don't have any of them here in Ontario or Quebec for that matter. There are not many of them in Canada at all. There's just a couple hundred from my understanding, and they're mostly in the prairies. I think most of them do work for some kind of, I'm not sure what level of government they work for, but it might be federal or provincial government. So I'm not sure how they're regulated, or they do have to work in rural regions, as you mentioned. I'm not too familiar with it.
Okay. So the next question is a big one. A lot of dentists that do work in private practice and accept patient or public insurance programs say that it's essentially charity work, as reimbursement is oftentimes less than cost. And as a result, there's a lot of skepticism from the dental community towards a single payer universal dental care system. So having worked for and administrated publicly funded clinics, how do you think this issue can be resolved? Dr. Nguyen, would you like to start us off?
Sure. So that certainly is a concern for a lot of dentists. Here in Canada, most provinces, most dental programs, public dental programs would reimburse anywhere from 70 to 90% of the provincial fee guide. There is an exception, that's Ontario, who pay way less. We're looking at under 45%, right? So yeah, it is basically you're losing money on a patient, right? So that is certainly a concern here in Ontario specifically. I mean, I agree. You can't really work at a loss, right? You're not going to be able to take on, you can't have a large proportion of your clientele reimbursed so little. I mean, overhead costs in dentistry are pretty high. So if we're talking about 45% reimbursement, that's well below what you would, hardly below the overhead, right? Can't even cover that cost. So certainly, I think they should be reimbursed a bit more to incentivize dentists to accept these programs more. But other than that, it's not, we don't necessarily have to go completely towards a universal dental program in Canada. We could also look at what's called Denticaid. Basically, it's just providing coverage for those who don't have coverage right now, right? So anyone with private dental insurance would still have that coverage, and those who don't have any coverage would enroll in a public dental insurance of some sort, right? I think that's what they do in Quebec with drug coverage, right? So those with insurance can have their own coverage, but otherwise everyone would be on some kind of coverage, whether it's public or private. So it's certainly an option in dentistry, perhaps to consider. It wouldn't be quite as disruptive as having a universal dental care program, right? The other thing, though, is, like I mentioned earlier, public dental programs are really confusing here in Ontario. You know, we're dealing with so many programs, and many private offices don't know who they're supposed to be billing for the work that they're doing in certain cases, right? Because there are so many program administrators for different programs. So simplifying that would certainly help a lot, I think. But yeah, no, I don't really have a simple solution for this. Certainly, if a larger proportion of your clientele is publicly funded, you do lose some of the control over the fees, right? As doctors talk about all the time here in Canada. So it's certainly a concern that I understand. I don't have an answer to that.
Yeah, there's a lot of issues that you brought up that would need to be addressed. And, you know, as you mentioned, public health model of public health dental clinic is not necessarily ideal for everybody, but also people can't be taking a loss in their private clinics, too great a loss. So there's
right. I mean, there is definitely a place for public and private funding of dental care and public and private delivery of dental care. It doesn't have to be all or one or the other, right?
Mm-hmm. Yeah, absolutely. A lot of very smart people are working on this as we speak, and we're hoping that they'll find some good happy medium. Dr. Lynn, how about from the Seattle perspective? How would you answer that aforementioned question?
So it's pretty similar here in terms of what Medicaid reimburses to private practice dentists. They don't pay enough to cover the overhead for them. But I think the government kind of expects them not to take them because we have so many community clinics, especially in urban areas, who can sustain themselves financially with the per visit grant that the government gives. But if we were to get universal dental care, for sure we need to increase reimbursement from what it is right now. The government will just need to have to put aside more budget for the dentist salaries. Medical care in Canada is universal and physicians are making very decent salaries. I don't see why dentists should be an exception to that. And I don't think the government expects dentists to do charity work if dental care were to become universal, right? The whole system will have to change. And realistically, I don't know about the Canadian Dental Association, but the American Dental Association is very, very powerful and have a lot of money and lobbying power. So if the government were to install a universal dental care system and cut the dentist salaries drastically, they're going to have a lot of power to try to block it. And also, I think if universal dental care were to be implemented, there's definitely going to be non-essential dental work that's not going to be covered, like cosmetic prosto or elective ortho. So, if some dentists don't want to go along with the public system, they could go into private. I think there's going to be a private sector that's going to thrive at the same time as a universal dental care system.
Mm-hmm. As an aside for those listening right now, if you go to our YouTube page and you go to our first video, we do talk about this a lot with Drs. Paul Allison and Dr. Carlos Quinones from McGill and Toronto University of Toronto, respectively. So definitely check that out after this talk. All right, and back to the talk. Before we finish off, are there any final remarks on publicly funded dental care. In your opinion, what works well in your clinics, what doesn't work well, and what would you change in your clinics to adapt them to a universal or a single payer system for basic and preventative and essential services? Dr. Lin?
I think one of the aspects that works the best for public funded dental care is how clear it is on what's covered and what's not. Right now, I think there's way too much waste on admin work because of the complexity of the private insurance system. I work part-time right now in a private clinic as well, and the amount of time that you see the office manager spending to just call different insurance companies to ask about specific coverage questions about, one specific patient is just really overwhelming. And then you have the insurance companies that have to hire all these people to answer these phone calls, and all these expenses don't yield any increase in the quantity or quality of the care. So I think a universal dental care system with single payer is going to eliminate those wastes. There's just one aspect of the current payment system in FUHCs in the US that I think is lacking a bit is, as I said, we're paid per visit from the patients. And because of that, the way that the treatments are done is not very efficient. For example, my schedule, if it was full, it would be 22 patients a day. And for every, they want to make the patients come back as many times as possible to get more reimbursement. So every patient above 14 years old needs to come back once for an exam and a separate time for a cleaning. So they have to come back like 4 times a year just to get their preventative care. And then treatment appointments are only 50 to 60 minutes as well. So we can only do 1 or 2 fillings per appointment. So some of them that have rampant caries have to come back 10 plus times to finish their treatment plan. However, if we were to have a universal dental care system and the payments were done by procedure, I think there will definitely be a tendency for dentists, unfortunately, to overtreat. So, I don't know what the solution to this problem is yet, but that's one problem that I can see.
Mm-hmm. It seems like there's middlemen and gaming of the system, and it's hard to avoid that. So a system that is a single payer would have to have some pretty tight overwatch to ensure that this kind of behavior doesn't happen. Dr. Nguyen, do you have anything to add?
Yeah, so I mean, we have universal healthcare here in Canada, and Canadians are rather happy with that system, right? I mean, things can always be improved, but generally, I think Canadians view it favorably compared to what we have, what they have here in the US, right? But that doesn't extend to dental care in Canada, right? It's still very much private, mostly privately funded, and Canada actually spends less per capita on public dental care than the US does, roughly half, in fact, per capita. So there's very little public dental funding here in Canada. I mentioned there are all sorts of programs, but there's very little funding in it. So there are all sorts of gaps for those who just make or have income just slightly above the threshold to qualify for the programs, right? And they still don't have the means to pay out of pocket for dental care. So certainly there are many gaps that could be filled by having universal dental care. And I think Canadians do generally believe it's a good idea. It's needed. I mean, the last provincial election here in Ontario, all three major parties ran with dental care in their platform, right? And that's how we ended up with a new program here in Ontario just launched last year for seniors. And I think universal dental care made it on the throne speech a couple of years ago in Trudeau's government, just to look into it. They're not committing to anything, but to look into it, right? So there's certainly, I think, a need for it and a recognition that it would be good. But like you mentioned earlier, there are all sorts of problems with reimbursement and whatnot, right? So I think it can certainly help. It's just, I don't know if it, and again, like I said earlier, I'm not sure if switching to the single payer system really is the answer, or just supplementing those who don't have coverage yet, right? And the other part, I suppose, is what we see here in Canada is those on with public dental coverage still end up reporting poorer oral health than those who don't have coverage, those who have no coverage or those who do have private dental insurance, right? So even if you have coverage, it's not enough to necessarily solve the problem of poor oral health. There are other things involved, like social determinants of health and other things that can be addressed to generally raise the level of oral health in the lower income population, right? So coverage is good, but it's just one part of the equation, right?
Yeah. Yeah, that's a very important point that can always be more can always be done to address these social determinants of health. You brought up, I'm very glad that you brought up the Canadian universal healthcare system. And I just want to take an aside to talk about the coalition and why I kind of joined. As a Canadian, I'm very proud of our universal healthcare system, and I enjoy it, and I see it helps my family, helps my community. And overall, I'm pretty glad it exists. And as a future dentist, I believe that the mouth is part of the body and it should be taken care of. So I guess the coalition for me is an effort to reconcile those two truths, that universal healthcare is something that I value, and the mouth is part of the body and it's important for our health. And so if anybody listening or anybody watching feels similarly or is attracted to the message you're advocating for a universal dental care type system in Canada, please reach out to us. You can engage with us on Facebook, on Twitter, on Instagram, send us a message and we'll try to get back to you. We will get back to you. If you're interested in starting up a club at your university, at your college, in your town, in your city, anywhere, reach out to us. And definitely keep engaged. Keep watching our webinars, like our posts, share our posts. And we are working on a letter writing campaign currently, and we're working in partnership with various other groups. So we have two very smart people working on that letter, and that will be shared throughout our network and throughout our partners' networks for constituents to send to their elected officials to describe why they believe universal dental care system is a good thing for Canada, and to insert a little anecdotal evidence for that. I want to thank Drs. Lin and Dr. Nguyen for their time tonight, for their expertise, and for their words. And I want to wish them best of luck in their careers and improving access to oral health care. So thank you so much, Dr. Ireland, and thank you, Dr. Nguyen, for joining us. Before you log off, we're just going to see if we have any questions from the chat. So Sam is going to relay those to you.
Sure. So hi, everyone. Thanks again, Dr. Lin and Dr. Nguyen, for your really insightful talk. I'll just bring a few questions from our audience. And the first one is, how can a new dental graduate in the US or in Canada go about becoming involved in practicing in community clinics? Is it recommended that they have some private practice experience prior to doing so, or have completed a residency? Maybe Dr. Lin, you can get us started on that.
Yeah, so in the US, you could go into community clinic practice right out of school, but it is a minority of people. Usually people have some experience in private or have a residency. I'd say if you're really, really dedicated and you really, that's what you want to do, and you want to have a higher chance of getting in, there are a lot of community clinics in the US that also have residency programs incorporated. So you can do an AEGD usually in those clinics. And once you have a foot in, you do a year with them. And if they like you, they will hire you right after residency. You don't have to, of course, any residency that you do, GPR or AGD in Canada or in the US, is going to boost up your CV to get into a community clinic.
Okay, thank you. And Dr. Nguyen, how is it in Canada?
I don't really know about the rest of Canada. I can speak about what we do here in Ottawa. A majority of what we do is emergency care. So we certainly want dentists who are comfortable in quickly diagnosing and treating within the same appointment if possible, right? So we have patients coming in with pain and we want to get them out of pain on the same appointment. So some experience is usually good. Now, it's not to say that we never hire anyone with little experience. It's always possible to train them. I mean, Dr. Lin mentioned earlier, it's a group environment. It's always nice to work with other dentists, consult with the other dentists when you're not sure, especially when you're a newer dentist. It's a very good support to have. So not to say it's not possible, but generally we do prefer someone with a bit more experience.
Okay, thank you. Our next question is, do you have any access to work in the OR or with nitrous sedation, for example, for childhood caries through these community clinics where you're working? Dr. Nguyen, maybe you can tell us first.
Yeah, in our clinics currently, we don't use any form of sedation. We do have access to nitrous oxide sedation, but we haven't used it in a while. We had pediatric dentists working in our clinics in the past, and they were the ones using it. I mean, Ontario now requires dentists to register to use any form of sedation, including nitrous oxide sedation. So that is a bit more onerous on the dentist, and if we're not using it very commonly, some dentists might opt not to use it, not to register for it. So in our practice, most of our dentists don't deal with nitrous oxide sedation. So no, currently we're not offering it. In the past as well, like I mentioned, we had pediatric dentists working in our clinics, and they might have had privileges at certain hospitals for general anesthesia, but currently through Ottawa Public Health, we don't have that access. We do work with the hospital-based clinics. We deal with them a lot, but our employees don't work in there directly.
Yeah, we do have nitrous oxide too, and we use it pretty frequently. We have a lot of pediatric patients. If they only need limited treatments or they're cooperative enough, usually we would just add nitrous on top of that. Right now, we're not because of COVID. Usually we use it quite a lot. But if they have extensive needs and they need sedation, usually we would just refer them to pediatric dentists. None of our employees have access to ORs or can do GA. Our community clinic, we're not allowed to do moderate sedation with oral sedatives, but I know most other community clinics in the greater Seattle area do. I think it's just the decision of the dental director.
Thank you. I'll just bring then our last question is, we touched a bit about this earlier in terms of eligibility for patients at these community clinics, but someone is wondering how we would service the homeless community if they need to have some kind of a proof or documentation about their income, which they can't provide. Dr. Lin?
That's a good question. I do have homeless patients. but I believe if they were to apply for sliding scale, they need to have some proof of income. But most of the homeless people, patients I have are on Medicaid. So they probably have access to some social services that help them apply for Medicaid. And once they have that, then they can have the basic care all covered.
And Dr. Nguyen?
As I mentioned earlier, we have volunteer dentists in Ottawa who work at the Ottawa Mission, which is a homeless shelter. So that's probably where most of the dentistry is happening for the homeless. We do have a clinic not far from that Ottawa Mission clinic. One of our clinics is not far from there. We do see some homeless people there once in a while. As I mentioned earlier, if someone comes in and they're in pain, we're still going to see them, right? Otherwise, once they come into our clinics and they are not covered under any program, we will try to get them on a program one way or another, right? So we can provide them information on which programs they might qualify for and how they might apply for those programs. Generally, when we're talking about someone who might not have proof of income, we would probably just refer them to our social community and social services departments and have them make the determination of eligibility. So I don't know what happens on their end. Otherwise, once they're in clinic, we just treat them on an emergency basis.
Okay. Thank you for shedding a bit more light on that. That's all the questions we have for tonight from the audience. So if anyone has anything else that they were curious about afterwards, again, feel free to message us through Facebook or Twitter or our other social media platforms, and we'll try to get you those answers. I'll just see if Henry has any closing remarks he'd like to make.
No, that was excellent timing. It's 2 minutes below the hour. So thank you once again for joining us. It was a great conversation. I really enjoyed it. And with that, if there's no more questions coming into the chat, we're going to log off and say good night to everybody.
Thank you.
Right.
Good night.
Thanks.
Thank you.
Bye.